Hi, my name is Camelia Douglas, a student at Eastern Kentucky University in the Department of Baccalaureate in Graduate Nursing, and today I will be presenting the Cognitive Behavioral Therapy Protocol for treatment of adolescents with depression. Depression is a major issue amongst adolescents, particularly for those ages 12 to 17, negatively affecting quality of life. Left untreated, depression can also carry a high burden of disease. Therefore, implementation of a consistent intervention, such as cognitive behavioral therapy or CBT, for this population is needed to help treat depression. Also, due to the potential for increased suicidality with antidepressant therapy alone, due to a black box label warning issued by the USDA, alternate and adjunct non-pharmacological therapies such as CBT must be considered. According to the National Institute of Mental Health, approximately 11% of adolescents have a depressive disorder by age 18. In 2012, 6.3% of the U.S. population had at least one major depressive disorder with severe impairment, accounting for about 1.5 million adolescents. CBT has shown to be an effective mode of therapy for treating depression in adolescents after at least 3 months when combined with antidepressants. According to the Brent et al. Study, 58% of adolescents had an adequate clinical response to CBT therapy as adjunct therapy than any antidepressant alone. Therefore, a cognitive behavioral therapy protocol will include 3 months of combined therapy of antidepressant and CBT therapy. The objective is after 3 months of combined therapy, there will be a decreased score from baseline on the Child Depression Rating Scale Revised, also known as the CDR-SR. The methods of the CBT protocol will include a sample size of 50 adolescents selected from a community clinic at the Saluda Center in Rock Hill, South Carolina. Inclusion criteria will be those ages 12 to 17 with a diagnosis of depression who have also been taking an antidepressant for at least 6 months. Exclusion criteria will be any participants who've had a previous suicidal attempt or any suicidal ideations within the last 6 months and a recent suicidal attempt or ideation. If a participant has any suicidal attempts or any suicidal ideations throughout the study over the course of 3 months, they will be excluded from the study and offered further treatment. This CBT protocol will include a registered nurse who will be responsible for performing or administering the CDR-SR assessments, and a psychiatrist and psychiatric mental health nurse practitioner who will be responsible for administering the CBT sessions for each participant. We will start with consent, which will be obtained, since this is a protected population, by the legal guardians and parents of the participants, and verbal assent will also be necessary from the adolescents themselves. A baseline assessment will be done using the CDR-SR scale to determine the level of depression for each participant. CBT will be performed every 2 weeks for 1 hour each in group sessions with 5 groups, 10 participants in each group. Each participant will be reevaluated during clinic visits once per month at the end of every month. And again, this will be administered by the registered nurse. Since the registered nurse, psychiatric, mental health nurse practitioner, and psychiatrist are all part of the staff, and this will take place during regular work hours, there will be no cost for salaries of these individuals. However, there will be a cost for printing the CDRS scales. So printing costs will be approximately $20. After implementation of this protocol, the hope is that CBT will be a standard for helping to treat depression in adolescents. CBT is a simple intervention that can be combined with existing treatments and implemented to help treat depression in adolescents. Although it must be performed by trained professionals such as psychiatrists and psychiatric mental health nurse practitioners, CBT is cost effective. It can also be done efficiently in group sessions, reducing the amount of time for treatment for each adolescent. I would like to provide a special thanks to the following for facilitating the completion of this project. All 50 participants and their parents and/or legal guardians who are willing to be a part of this study. Also, all Saluda staff, including administration, RNs, psychiatric nurse practitioners, and also psychiatrists, and doctors Donna Corley and Jill Cornelison as educators for EKU's graduate nursing program for their persistent guidance through completion of this project. Thank you.